this module we talk about how to deal with a casualty who is choking, a casualty who's in clinical shock, and a casualty who's in seizure. The first thing we do if we have a casualty who's choking is encourage them to cough. That's the body's natural response to try and generate some pressure and get whatever it is up and out of the mouth. If the casualty can't cough, then we know it's not a partial obstruction, it's a complete obstruction. So if they can't cough at all, it's a complete obstruction and we need to go straight on to the next stage, which would be back blows. We also go on to back blows if the casualty can cough and the cough hasn't been effective. So we lean the casualty forward and we administer 5 back blows right in between the shoulders of the casualty. Now we'll demonstrate exactly how to do this on the practical day that you'll attend, and you'll also have an opportunity to practice this on each other using what's known as a choking vest. If we administer 5 back blows and they're not effective, we then move on to 5 abdominal thrusts. And this is the procedure that used to be known as the Heimlich manoeuvre. We administer 5 abdominal thrusts. If that's not effective, we go back to 5 back blows, 5 abdominal thrusts, 5 back blows, 5 abdominal thrusts, until either the object comes up and out of the mouth or the casualty will fall to the ground, they'll become unconscious, they'll stop breathing, and we need to administer CPR. We'll talk about and we'll show you and get you to demonstrate how to do both back blows and abdominal thrusts as mentioned on your practical day, and we'll also talk a wee bit more about what happens or some of the difficulties we might have in administering our rescue breaths if the object hasn't been removed. So clinical shock is inadequate tissue perfusion, and it's caused by a fall in blood pressure or blood volume and requires immediate emergency treatment to prevent either permanent organ damage or potentially death. So without adequate blood volume, the pressure drops and the body soon collapses. Bleeding causes both the volume and pressure to drop and is the most common cause of death from shock, and this is called hypovolemic shock. So this slide just gives a visual picture of what we've discussed there. So there might be in the far left there an issue with the pump, so the heart's not pumping properly. We could have blood pressure and blood volume dropping as a result of a bleed, or we could have what's known as dilated blood vessels, so where the blood vessels essentially expand and that causes a drop in the overall volume of blood and blood pressure. So how's your casualty going to present if they're in clinical shock? They're going to have rapid but shallow breaths, they're going to be dizzy, they're going to feel weak, they'll have a rapid, weak but thready pulse, their skin's going to be cool, clammy, mottled, and they're going to have cyanosis, this blue tinge to their lips, etc. Thirsty and have a dry mouth, and they're going to feel fatigued as well. So why does the casualty have a dry mouth? Well, when your body's going into clinical shock, your body tries to keep all of the vital blood flow and oxygen for the vital organs. Your salivary glands require blood flow in order to produce saliva. There's no blood flow to the salivary glands at the back of your mouth because it's been kept for the vital organs, so there's this sensation of having a thirst and a dry mouth. At that stage, we wouldn't want to give the casualty anything to eat or drink because they're likely to be losing consciousness, and also they may require surgery at a hospital, which may well delay that. This picture highlights the position that we want to put a casualty into who's suffering from shock. So we only do this if the casualty is conscious or if they've just fainted. So we want to elevate the legs to about 15 to 20 degrees, and that will just return blood flow to the major organs. We don't want to elevate the legs at too steep an angle, otherwise we won't then be able to get blood flow back to the legs, and if we starve any tissue of blood flow and oxygen, then that tissue will start to die. So seizures are an upset in the electrical activity within the brain, and it leads to seizure activity. Any seizure that is brought on following a head injury must go to hospital. Seizures can be caused by epilepsy, but they can also be caused by other things as mentioned, like a head injury or potentially tumours, etc. Those with epilepsy have a tendency to have repeated seizures, which start in the brain. They sometimes get some kind of warning smell or taste or aura that gives them an indication that they're about to go into seizure, and that enables them to limit the immediate danger or damage that might be caused. Most seizures are short-lived and self-limiting, so the body's quite clever in that sense. So the casualty will not be breathing or holding their breath during the seizure, so they generally come out of the seizure before oxygen is an issue. All seizures are different. Some people's seizures are completely controlled by medications. Other people have occasional or more frequent seizures. Absent seizures or petit mal seizures is when the person stares briefly or blankly and is totally unaware of their surroundings, so they can be talking as normal like I am now, and then all of a sudden staring blankly into space, and then they're back in the room again. Partial or focal seizures, there's an altered awareness and strange behaviour such as lip smacking, so that's just repeatedly closing the lips together, maybe fiddling with clothing, etc. as well. Your tonic-clonic seizures or your grand mal seizures is where the person goes very, very rigid, they'll fall to the ground. They then go through this convulsive jerky phase, so the fitting phase. So breathing's affected, the lips can turn blue, the jaw is generally clenched, so they might burst the inside of their gums or bite their tongue. So there's quite often kind of frothy, bloody saliva as a result of that, and they can lose control of their bladder and or their bowels as well. The main thing we need to consider with the treatment of seizures is just remaining calm. It's not a particularly nice thing to see, so it can be quite distressing for the first aider and bystanders. Our main role as a first aider is we want to protect the head from further injury. So that might be cushioning or cupping the head, it might be putting down jackets, pillows, bits off your sofa if it's in the house, whatever it might be, putting yourself between a goalpost and your keeper if you're on a football pitch, for example. Time how long the seizure lasts, so if the seizure is within the normal pattern for that individual, there's not really a need for them to be in hospital, so you don't need to phone for an ambulance, but that requires you to know the casualty. So if you don't know them, then you need to treat it as a first time seizure and phone for an ambulance. Loosen clothing around the neck, remove glasses as well, just so they don't get damaged and cause a casualty further injury. In sport, we might be cutting off kind of compression garments, Under Armour clothing, etc. If they're asleep afterwards, just protect them, allow them to continue to sleep, so that's how they recover. However, if they're unconscious after the seizure, then we need to stick them in recovery position, and if they're unconscious for more than 10 minutes, then it means they haven't fully come out of the seizure. They're in what's known as status epilepticus, and that's a medical emergency. We must get them to hospital. We're going to monitor airway, breathing, circulation, and we're going to monitor them in the AVPU scale, so only when they're fully alert can we let them go about their business. Don't forcibly restrain the casualty, that's going to cause more damage. Don't put anything in their mouth, they will lock down on that, so they can take the tip of your finger off. Don't move them unless they're in an unsafe position. Don't try and wake them up, and obviously don't give them anything to eat or drink until they're on the AVPU scale, they're fully alert, because there's a risk that they're going to choke on it. So we've mentioned some of these already, but these would be the reasons for phoning for an ambulance. So if it's a first time seizure, if the seizure is different from normal or unusual, so out with the normal pattern for that casualty. If the seizure is repeated, so if they have multiple seizures without regaining full consciousness, or any one seizure that lasts for more than 2 minutes, then we need to phone an ambulance. They're in status epilepticus. If the person's having breathing issues after the seizure has finished, if the seizure is associated with a head injury, so if it's a clash of heads in a football pitch or rugby pitch, for example, or if you're concerned in the casualty in any way. If you don't know the casualty, just bear in mind, as far as you're concerned, it's a first time seizure, unless there's somebody else around, family member, etc., who can tell you otherwise. So that's us at the end of this module, just an opportunity for you to reflect, make a note of any questions that you might want to ask your tutor assessor on the practical day, or you can feel free to post any questions in the discussion forum on Canvas.